I'm Catherine Henry. I'm an attorney, mediator, and restorative justice practitioner. I want to share with you today some of the things that are going on with COVID-19 and have us look at particular aspects and key issues that are in dispute. You might be asking, why would you listen to me? I'm an attorney. Well, a lot of what we're dealing with is dealing with constitutional rights. It's dealing with our statutes and our laws on point. So why would you listen to me on this? Well, like I said, I'm a licensed attorney. I am admitted to practice in the state of Michigan, the Eastern District of Michigan U.S. District Court, the Western District of the Federal District Court, the United States Supreme Court, and the Saginaw Chippewa Tribal Court. I've also been working on a variety of issues relating to constitutional freedoms on various cases all the way up to the United States Supreme Court. And as a undergrad, I studied political science and had a lot of experience with taking courses such as statistics and other things, and so I'm not holding myself out to be an expert in those mathematical or science categories, but I do have enough experience to be able to interpret the data that is put out by the experts, and that's what we're going to try to share with you today. But I'm not here alone, as you could see, so, all right.
My name's Martin Dubravec. I'm an allergist and a clinical immunologist. I have a practice in Cadillac, Michigan. I have been a physician for approximately 22 years, and my practice specializes in allergies, asthma, and immunologic disease.
So, to get right into why we're here today, I guess the most simple question we could start with is, in general, on any one of these pieces of information that's coming out and being shared with us, would you say that there are studies or medical opinions or public health officials who are coming out with opposing statements on each and every issue that's been presented to us by the media? Or would you say that the medical community and scientific community is wholeheartedly all supporting each and every one of these positions brought to us by the media?
Well, I think the medical community has been at first somewhat guided by these various models. And when the virus first came to the United States in January, we as medical professionals try to work from some type of data, whether it be predictive data or actual data. And when we started looking at this, we only had predictive data. And therefore, we had these wild estimates as to how many people would die of coronavirus, how the virus was transferred, and assorted other theories with regard to the virus. Well, now we're in April, and we have a lot of data that is homegrown right here from the United States. It's very transparent data. It's data right from the CDC, from the NIH, from individual states. And we can look at that data as healthcare professionals, and as scientists, we can look at that data to see where we are, where we have been, and where we should be going. The predictive models are really becoming outdated because now we don't have predictive models that we have to rely on. We actually have data, hard data that we can rely on. And so I think what we're seeing is we're seeing more and more healthcare professionals say, hey, we need to look at data that is real-time data and not so much look at predictive theoretical scenarios.
So, if I'm understanding you correct, you're saying that although the medical community would value predictive data in, say, a scenario of January or February here in the United States regarding COVID-19, that overall the medical or scientific communities have placed much higher value on actual data rather than the predictive data that the modeling talks about. Is that
Absolutely, and we can see that in just the outcomes of the predictive modeling. I mean, in January and February, we were hearing these god-awful numbers of 2.2 million people dying of coronavirus. Then it went down to 200,000. Then we were at 95,000. Then the models went down to 81,000. And right now, they're predicting 60,000. They also talked about death rates, that is, the number of people with the virus versus those who died. And so they were talking that the death rates of people dying of the virus compared to all those who had it at about 3 or 4%. Now we have information that is showing that data was wildly off, and we can expect a death rate similar to or less than influenza.
So I do want to ask you about some of those points that you just brought up. So let's start with those who have currently have or have had COVID-19, or as we'll talk about throughout this, I might just reference it as coronavirus, even though we're specifically talking about the current COVID-19 coronavirus, but we do recognize that there are others that fall into that category. So in terms of talking about who has had it, are you aware of the study, or I guess I should say the information that came out of the state of Hawaii within the last week or so about that they predicted that a vast majority of their population had already had the virus as early as January, not just one or two, but that many actually had it in Hawaii?
Yeah, and I think that is something that we can expect here in the mainland United States also. In California, that's being borne out with recent information from Dr. Bhattacharya, who has looked at Santa Clara County, California, Los Angeles County, California, where in Santa Clara County, California, for instance, anywhere from 50 to 85% more cases of coronavirus have been noted by antibody testing, which looks at people who have had infection. So if we look at the patients who have been infected in the past, we look at antibody testing. These are infection-fighting proteins that the body produces after an infection to prevent you from getting sick in the future. So that's what a vaccine does. It stimulates, it makes your body, your immune system, produce these antibodies. So you can measure those to look at past infection, or else to look for whether or not you've been immunized. So if we look at Santa Clara County, California, we have 50 to 85 times the number of people who have been exposed to coronavirus versus those who actively have it. And so therefore, that's why the death rates are now being measured as much lower, because you have a large number of people, as others have said, large number of people, few numbers of deaths from the virus.
So is that the same thing that they found in the, I want to say it was just 3 days ago, April 23rd, that in the state of New York, they had tested over 3,000 people, not just in the city of New York, but also in, I believe, 20-some counties around, where they found on average that 17% of the population actually had the antibodies. Is that the same thing we're seeing then between California, Hawaii, and now New York?
Yes, it's the same process. And really what that is it represents one of two things. It represents either that this virus is not very deadly for almost anybody, that a lot of people get it, or what it means is that we developed herd immunity. That is, enough people get exposed to the virus then cannot continue to grow in the population because enough people are immune to it and the virus dies out. I really think that is the reason why we're trending down in Michigan. That is the reason why New York City is recovering. It's because of this concept of herd immunity.
Okay. So before I definitely want to ask you about herd immunity and some of those other things you mentioned, but I guess I want to just paint a bigger picture for the people that will be watching this. So in terms of antibody testing and the findings that many, thousands, hundreds of thousands of people are actually have actually had that here in America without having all these other symptoms that we're seeing that are so deadly. Is that the same thing that the phlebotomist from the city of Chicago was finding when she said 30 to 50% of the people she's seeing actually already had the antibody, were positive for the antibody testing, and that was, I believe, way back on maybe April 5th. Is that the same thing as with we were just talking about with New York, California, and Hawaii?
Yes, yes.
Okay. So, as far as you're aware, off the top of my head, those are the main ones that have come to mind, but I do seem to recall there have been other studies and other testing done in various other states across our country. Is that correct, that we're doing that in other places?
There are studies that are being done in a variety of places. I don't have those off the top of my head, but there is an interesting study, for instance, in Italy, where they looked at people coming in for blood donation. These were healthy people, because you can't give blood if you're not healthy. And if I remember right, 40 out of 60 people that they tested had antibodies to coronavirus.
Okay, so we're seeing all over the place, whether it's 30 to 50%, or in the other study 50 to 85%, or in Italy it's 40 to 60%. We're seeing that on average 50% and up of our population has probably already been exposed to the coronavirus and is now in the stage of having antibodies. Is that what we're saying? That's what these percentages are?
Well, the percentage in Santa Clara County, California is about, if I remember right, it's 4%. They would extrapolate it to 4%.
That 4% have already had the virus?
That 4% of the population they tested has antibodies to the virus.
Okay.
Which is, but that's looking at people who have had past infection. If you look at the number of active infections, what it's showing is it's very small. The number of people we're able to pick up with active infection is very small compared to the people who have been exposed.
Okay, so we might not have exact numbers at this point, but it's clear what the numbers are showing, that we have a lot more people being tested that are showing they had it previously, may not even known it, than the people that are currently
Correct.
being tested as positive now.
Correct.
Okay. In the event that we end up having to break our video here and start over, I want to just take a moment real quick and say that I am Catherine Henry. I'm an attorney, and this is Martin Dubravec, and he is a doctor and expert immunologist, and we're here talking about the concepts of COVID-19 and what all the numbers mean and what all the studies mean, and trying to help you sort through some of that information. So hopefully I'll remember to do that every now and then, just so people can catch who we are as we might need to break up these videos. But so we talked about, let's see. Well, one thing, you mentioned that you had the ability to view the video that was posted maybe within the last day or two from two doctors that are over in California, and I believe that they are the co-owners of some sort of medical care facilities. I believe that they have 7 different locations that are maybe urgent care type of facilities, and that they had been testing over half of all the testing done in their area. They had done over half of it, which was over 5,000 people that they had been testing for COVID-19 and whatnot. Have you had the chance to watch their interview?
Yes, I watched most of it, yeah.
Okay. So in general, would you say that overall what they were talking about seems medically or scientifically sound, or in general does it look like, oh, that's just, a bunch of garbage and we shouldn't pay attention to it?
No, I think it's medically sound, and they also presented data from the CDC and also other studies, but they are driven in their findings by data, and you can't refute those numbers that they got from the CDC.
Okay. So speaking of the CDC, hopefully I'm not jumping around too much in our topics here, but they mentioned in their video that ER docs all over the area from where they practice are being forced to or pressured to add COVID-19 onto causes of death or death certificates when they are filing them. And likewise, they've had contact with some physicians in Wisconsin and other states who are questioning why are we being pressured to add COVID-19 onto our diagnoses of patients that we don't believe have anything to do with COVID-19. So have you, I believe one of those doctors in there was referencing something about hospital administration, or that it might be, there were some reporters asking about it being, well, that doesn't make sense. Why would local hospital administrators want to do that? Is it your understanding that the origination of inflating those numbers comes from the local hospital administrators or health departments, or is it your understanding that directive actually comes from higher up?
My understanding from what I've heard from doctors, and I can't speak directly for Michigan, but from other states such as Minnesota, is that the directives are coming from the state health departments. The other thing to keep in mind is that the recent legislation, the CARES legislation, which the federal government has passed for coronavirus funding, gives hospitals 15% more for Medicare patients that are diagnosed with coronavirus. So if there is a diagnosis of coronavirus on the patient's chart, my understanding is that the hospitals will be paid 15% more by Medicare to treat these patients.
So that would be a big incentive for them to add a diagnosis where they would otherwise not do
Yeah,
that.
I think there could be some pressure on physicians to add that, and of course we would hope that the physicians would be honest and not be pressured from for financial reasons to do that they would practice medicine and not try to somehow fudge the data on patients' charts.
So just in terms of speaking in reality, so I'm not trying to say that if hospital administrators are strongly pressuring their doctors to add COVID-19 to a cause of death or to other diagnoses so they can get this additional funding. Although I think that we need to not be doing that if it's not true. Would you say that that ties directly in with the fact that hospitals, especially in states such as ours here in Michigan, they're at the point of, I don't know if they'd be at the point of filing for bankruptcy, but they're struggling financially because the executive orders have shut down all non-essential surgeries and other medical care, and so they're trying to figure out how to keep things going in the interim?
Yeah, I mean, let's just look at one healthcare system. One of the large ones in Michigan, in southeast Michigan, is the Beaumont healthcare system, and I'm sure a lot of people who are viewing this probably are familiar with Troy Beaumont or Royal Oak Beaumont. And this week they announced that they were laying off 2,475 employees. And this is in the midst of what we are being told is an epidemic. And why is that occurring? Well, because the hospitals are losing a major source of their revenue, which is elective surgeries. And I would argue that many of these surgeries are not elective. A hip replacement is not elective. A gallbladder surgery is not elective. And there is a risk when any of those surgeries are delayed. There are very few surgeries other than purely cosmetic surgeries that we can truly say are elective. And what's concerning to me is that these decisions, which I question whether or not they're even constitutional under the state law in Michigan, whether the decision to undergo surgery between a patient and their physician is being unduly interfered with by by governmental actions in our state. That to me is quite troubling and should be addressed.
So, I guess I'll have to come back to the original train of thought I had there, because you bring up an important point as to the importance of the relationship between the doctor and patient. But I think something that you've alluded to is also the idea of patient autonomy. How important, how much is that emphasized with medical ethics when you're going through medical school or doing a residency or when you're in practice? How important is it that patients have their own personal autonomy, their own ability to make decisions about their medical care?
I would say it's one of the most foundational, if I can use that term, foundational aspects of medical ethics is patient autonomy, the freedom of the patient to make their own medical decisions.
So, would you say that when we are reducing the ability of, when our governor has put in executive orders that all medical facilities are prohibited from doing these elective or non-necessary surgeries or treatments or ordinary healthcare physicals and things like that, would you say that those directives prohibiting such care directly impacts the patient's ability to have personal autonomy in their own medical care?
I think it takes it away.
Okay.
I think it erases it. And, one of the things I should state is that, there are individuals who state that, well, we had to stop some of these surgeries because we didn't have the supplies and we wanted to keep supplies for those patients should they really need surgery, or if we have a spike in coronavirus cases. I'm all for that, okay? And that was, maybe in February, maybe March. But as I said before, let's look at the data. Let's see where we're at. And we certainly didn't have the Russian cases that were predicted. And we certainly don't have the continuation of significant amounts of cases that we had before, as evidenced by Beaumont laying off this week 2,475 employees.
And as far as you know, is that the only hospital system that is laying off people in the state?
No. Spectrum, which is a large hospital system in the Grand Rapids area, has announced layoffs. Munson Healthcare System in Traverse City, which services approximately 500,000 people or more in Northwest Lower Michigan, is laying off. For instance, in my community in Cadillac, the hospital-based urgent care clinic is now closed. So we're seeing this in a variety of areas. And I would also add, if we look at dentists in Michigan, I don't know how, of too many people who go to their dentist electively. and nothing against dentists, but they've been shuttered closed for weeks. And, what impact is that going to have on the health of the population? If someone needs a shoulder replaced, the more you wait on that, there's more scarring, there's more risk of complications, etc. So it's not a matter of just simply shutting down something that isn't going to kill a patient in a day or two. It's what are we doing to the overall health of Michigan by continuing this, what I believe is a very intrusive interference in the doctor-patient relationship.
So, real quick, I'm going to go ahead and try to let our viewers know, in case we have to do a stop in the video segment here. I am attorney Catherine Henry, and this is Dr. Martin Dubravec, an expert immunologist, and we are going through some of the main questions, some of the important topics about COVID-19, and helping people to understand what is really going on and how to go through the data and how to go through all of the things that are playing out logistically in our communities across the country, and how to use this information to make good policy going forward. So with that being said, in the event that we are going to start a new video clip right here, I'll just say that you had just previously been describing that the ability of a patient to have personal autonomy and direct their own medical care is probably the most fundamental or important aspect of patient care. And it sounds like you're saying that a high second would be the ability of a patient to have that back and forth information and dialogue with their medical provider themselves, and that between the two of them they are finding the best ways to treat or diagnose or care for them, and to not have the state directives that try to get in between that relationship or prohibit personal autonomy from happening. So with that in mind, what we had talked about is that things that are being deemed as non-essential, hip replacement, we have mental health care that's been put on hold, we have dentist appointments, we have regular checkups and things like that. All of these things that by doing so, by having the state of Michigan having an executive order that prohibits those kinds of things, we are getting in between or actually dissolving the personal autonomy of people to direct their own medical care. But aside from that, I guess my question for you is, would you say that what's happening with the use of hydroxychloroquine, that is also, are the government directives to stop the use of hydroxychloroquine for these COVID-19 patients, is that affecting the ability of patients to have personal autonomy in their own medical care? Should a patient be able to say, you know what, I understand that this is not approved yet, and that efficacy to treat COVID-19 has not been established. I also understand that with any medication, there's going to be risk of side effects, but I would like to have it because I am experiencing some severe symptoms of this COVID-19 virus, and I would like to have that ability to try that medication. Do you think that's something that the patient should have the personal autonomy to make that decision, or do you think it's better that the governor and others in the government be able to kind of say, nope, that's not what's best for you, we're going to save you from that?
Yeah, well, I think it should be in the hands of the patient with regard to those medications. The jury is still out. I think we can safely say from a scientific perspective, the jury is still out. Preliminary data looks very good if given early in patients. I think there's an argument to be made that if the patient unfortunately is at death's door in the ICU, that those medications would not be very helpful. But I think there's very good data to show that the use of hydroxychloroquine and azithromycin together can be of benefit in the appropriate patient. And yes, it comes down to the patient and their physician discussing those options and coming up with the treatment plan.
So I guess let me ask you this. Based on the VA study, which I'll get into more later, the main official involved in that study was just seen on a news interview, I believe it was on CNN actually, within the last couple days, and he was describing that the use of hydroxychloroquine was, it did not show that it was working well in patients that were basically on death's door, that they were severely immunocompromised, that their systems were shutting down for other reasons, significant underlying medical health conditions at play, but that it did work though in the veterans, he said, who are younger and who are otherwise healthy, who are not immunocompromised, that the hydroxychloroquine was actually seen to be working in those patients. So my question is even given that information, where it might be, if we could extrapolate and say, gosh, it really doesn't seem to work a whole lot in those who are severely immunocompromised or basically where their body's already getting to the point of shutting down, and then they want to try the hydroxychloroquine. What is your thought on should a patient in that situation who is on the verge of dying, should they be able to say, well, gosh, I know it hasn't worked for other people, but I'd still like to give it a shot?
Absolutely. Absolutely. Unless we can find that it truly is detrimental. In medicine, do no harm, right?
Mm-hmm.
That's the first thing that we're always taught is the most important thing is do no harm. So absent of that, without other more preferable therapeutics, certainly that should be entertained. And there are hospitals in New York where hydroxychloroquine and or azithromycin are recommended as treatments for COVID-19. So it's, there is some back and forth and some, I would say, some arguing among very good and talented physicians with regard to the use of these medications, but that's how medicine progresses.
So we talked about, in like the first segment we were recording, about the initial response to doing, right before we did lockdowns, Governor Whitmer issued an executive order that said no more non-essential medical services or dental services. So, and then it later got extended to veterinary services. So anyone who would have access to gloves or masks or the kind of medical equipment we might need to combat COVID-19, we're going to shut all of it down so we can make sure we don't run out. So fast forward a month and a half later, would you say that given what our numbers are being reported in Michigan, that we need to right now stay, have all of our medical and dental facilities stay closed, these non-elective procedures, that they need to stay postponed because we might still in fact run out of medical equipment? Do you think that would be necessary?
No, I don't. I think when we look at the massive layoffs that we've talked about before with regard to some of our health systems in Michigan, certainly we have an overabundance of healthcare personnel. Nationwide, we've had, they've overfactored the number of ventilators by a factor of 40 that we need, and also ICU admissions and hospital admissions for COVID-19 are significantly less than what most of the models or all of the models predicted.
And I don't know if you've heard, I just heard yesterday that I don't know if it was at the Ford Stadium or wherever it was, that Whitmer had put together this field hospital, and it was supposed to have 1,000 beds, and it was reduced down to 200 or something like that. It had maybe a few, 10, 20 patients at some point, and then my understanding is that that facility is actually now closed. Is that your understanding as well?
Yes, that's my understanding.
So let me ask, the models that, I don't think I have the name in front of me, but there was an epidemiologist, I believe, from the University of Michigan, who was on Gretchen Whitmer's press conference Wednesday afternoon. I believe it was actually two of them. I was listening on the radio, and so I only actually heard the voice of one of them when I was listening. But she was on there talking about her models. And what they did is they've now been doing models that show if we start May 1st and we progress 2 weeks to get to the point that over the span of those 2 weeks, we eventually, through different phases, end up where we are fully integrated in our communities and back in employment and things like that. She's trying to look at what would happen. So essentially, if the stay-at-home orders go away, what is that going to look like? And her report that she conveyed that Wednesday in this press conference was that the results were, quote, wide-ranging. Everything from essentially no new cases of COVID-19 to mass infection rates across the state. So is that your understanding that those are what some of the models are looking at?
Yes.
Okay. So basically, I mean, to dumb it down, if you will, what that says to me is they really have no clue. What the data is showing them right now is that they have no clue how human behavior and the pattern of human movement in the normal course of life is going to impact how COVID-19 would spread. Is that?
Yes, and we don't even know how it spread. I mean, it's a very reasonable assumption that it spread in the air. Okay, it is a respiratory bug. It infects your airway. Primarily, it infects the airway. It's been found in other parts of the body, but primarily that's how we get a lot of other coronaviruses, as well as this one. But we don't know how long it lasts on a countertop. Some research shows 18 hours it can last on various surfaces. A German researcher in Germany going to homes of patients with COVID-19 was unable to find it on certain surfaces. And
So he was in their homes, testing common surfaces, expecting to
doorknobs,
see,
and was not able to find it.
and not able to find it.
So at other researchers say 18 hours it can sit on plastic, various types of plastic, for instance. So we really don't know. The Undersecretary for Science and Technology in the Health and Human Services this week had some very interesting data that they were looking at in their lab, which showed that at a temperature of 70 to 75 degrees Fahrenheit and regular ultraviolet light, the virus would last, I think, at most 2 minutes. I don't know exactly the timing of that, but I think it was under 2 minutes. So, and that fits with previous data showing that ultraviolet light is very helpful in curbing the virus. And therefore we can expect that as we come into summer, that the virus, like a lot of other viruses, will become much less noticeable or less tracked. We can expect infection rates to go down quite significantly. But the bottom line is we don't know. And so when researchers say, well, we can expect a surge, we don't know. But what we do know is looking at Italy, looking at other European countries, the virus tends to follow an 8-week path. It's certainly following that right now in Michigan, an 8-week path. If you look at the overall trends of new cases, they're coming down. And so we can expect that to continue. And that, once again, is because of that concept of herd immunity that I discussed. Where enough people get infected, they become actually a wall for spreading the infection because they can't spread it. They're immune to it.
So, and you just said that we don't know, but I guess what I'm going to ask is, so let's say we're on that other side of this modeling pendulum, if you will, that so we might see no new spread, so none of these medical equipment supplies would be needed outside of their normal uses, or we go all the way to the other side where we're seeing massive spread. Do you think, based on your understanding of all the millions of supplies, the millions of items of PPE that Gretchen Whitmer has gone on these press conferences saying DTE has supplied, and I believe Ford Motor Company has supplied, and all these various other organizations in the private sector, and then we've had, I believe she said, some few hundred ventilators, I believe it was, that was coming from California, and then we had a few thousand of some other PPE or ventilators or other medical equipment that was coming from New York, that we have, my question for you, all that information included, do you think that should we get this big spike that they're anticipating, do you think that we would be able to adequately care for patients if all doctors and dentists and whatnot opened back up, had their normal practices, and then we saw this huge spike in COVID-19, do you think we would be situated where we could comfortably say, we're going to be able to take care of patients?
Yes. I think we so over-factored what we really needed. We have such an abundance of material. I can't imagine any scenario in which we would not be able to handle a theoretical surge in cases.
So, I guess let me ask you, in the video that I watched, I believe this is the source of the information. Just trying to think. Yes, it was in the video that I watched that had two California doctors that I mentioned in prior segments of this interview here, where they are frontline doctors working in they own 7 like urgent care type of facilities around California. They themselves have conducted testing on more than 5,000 people for the coronavirus. That they talked about this concept of what about stay-at-home orders? And here in Michigan, we're obviously under stay-at-home orders. So the specific question I have for you with that is, they mentioned that by ordering people to stay home, and then sometimes they go even further and talk about that you're supposed to stay inside, but specifically ordering people to stay home and purposely stay separated from other individuals outside of your household, that alone, for a prolonged period of time such as we're experiencing now, actually does more damage to the immune systems than it does to protect our immune systems, because then we need that common integration with all of those, common diseases and illnesses and things that are in our communities, that we gain immunities without even realizing it through this common intermixing with people in our normal course of life and normal course of business. Could you comment about that, the idea that if staying home, if ordering 10 million Michiganders to stay home, if that would help their immunity or if it might hurt their immunity? What is your thought on that?
Well, I think that's a common theory, that it, like a muscle. If you don't use a muscle, it atrophies. It becomes less strong, and it becomes weak. It becomes inefficient in what it's doing. But I would take it a step further. I would say that in Michigan, we never really shut down. We never really quarantined. What we did was we did a selective economic shutdown of certain businesses, because we still had Home Depot, we still have Menards, we have Meijer, we have Walmart open. And so we didn't really decrease people's exposure from each other and from the virus. And despite our lockdowns, we still had a spike in cases. And despite our lockdowns, we are seeing cases come down. I don't think the lockdown makes a difference immunologically, because we aren't doing that. In China, in Wuhan, they literally built a wall around the city. There were reports of apartment dwellers, their doors being welded shut in apartment complexes that had high amounts of COVID patients, and therefore those people were literally left to die. But what I'm saying is that the whole concept of that was a true lockdown. That was a true quarantine. But that's not possible here, nor did we do that. So although that's theoretically possible to have done, I don't think it happened here in Michigan.
Okay. So we have all these categories of workers who have been deemed non-essential, which is a whole other story. But even with those, even if we go with Executive Order 2020-42, which is now no longer in effect, it's now replaced with 2020-59. But 2020-42, which specifically said, no, you can't have landscapers out, you can't have, it was very restrictive on the amount of people that were out in the workforce. But even considering that, it'd be still ineffective to go to a more stringent approach to restricting the workforce, because as long as we're out buying groceries, as long as we're getting medications, as long as we even have, if we literally didn't leave our homes and we had UPS and Amazon drivers, or takeout, food delivery drivers coming to our homes, and we were in contact with them that way. Or I think in one conversation you and I had, we talked about Taco Bell. If you're sorry honey, that's one of my husband's favorite restaurants, but even if you have a worker or a couple workers at the Taco Bell drive-through window, and they never leave the restaurant while they're working, and the customers never come in, they stay in their cars, you still have that interaction.
Mm-hmm.
So you have, hundreds or thousands of customers coming through that drive-through window, having that that personal and that direct interaction with that person, with that drive-through window worker. So we're just not, in order to eat, in order to have medications, in order to go ahead and have the life-saving, urgent, immediate medical care services, we're just simply not able to do a true lockdown. So it's doing anything that resembles that. It's just for the sake of calling it a lockdown. It's not really going to do.
Yeah.
Okay.
And it's not necessary. We've seen states that don't have lockdowns and states that do, and their coronavirus cases per million people is the same or less. There's no difference. Neighboring states, and I've looked at it. You've looked at that data. It's been looked at by an economist, and there have been all sorts of adjustments for population density, etc. And it's just not necessary. And lockdowns don't work. We now have data that says lockdowns don't work. It's not just my opinion. We can look at the data. It's out there on the internet for anybody to see. On Worldometer, you can look up the cases of coronavirus for each state and compare them.
So, just so that viewers can know, we're not going to spend a ton of time going through that data right now, but what Dr. Dubravec actually put in his article from April 5th, actually the original article was March 29th, he did a supplement or update to that on April 5th, and you can see towards the bottom of that article, he actually has a chart that identifies comparing Michigan total deaths from COVID-19, Michigan total deaths per 1 million residents, versus the 8 states who do not have the stay-at-home orders, and what their death rates are overall, as well as their death rates per 1 million residents. And then he also went down and compared that. He took each state who had a no lockdown order in place, each of those 8 states, he then shared with neighboring states what their death rates look like. So, for example, Mississippi and Alabama were compared, and Missouri and Arkansas, Illinois and Iowa, then Colorado and Nebraska. Minnesota, which was compared with South Dakota and North Dakota that don't. Idaho and Utah are compared. And so his data, I cite his original article. So if you wanted to look at the information that was available on April 5th, because I don't think there's a way to really backdate and look for data with what was reported in those states at that time, his article is available right through my document that I have available online. I cite it. And then the document that my larger document that was called Michigan Executive Orders and COVID-19 Analysis is what I'm talking about. It is a 38-page document. In there, I have the numbers, the same numbers that he did. I just updated those. I looked at that particular day that I was writing on that page, April 15th. I gave you all the numbers then, which clearly showed the exact same trends. So although, as some viewers had pointed out on one of my videos, while you talk about the numbers, but maybe they basically started with the virus later on than Michigan did, or later on than Minnesota did, and so they're behind. Maybe they still have the same curve, but they're just farther behind. Well, this shows a progression of 10 days later, so we should have seen some sort of change or movement in the analysis and the numbers if that were the case.
And I would add that, I would also add that if you have, some people may say, well, the lockdown takes time to see benefit. You need time. Well, we've got time. You showed the time change. And despite 10 days later, we're not seeing any change. So, the lockdown 10 days later didn't make a difference.
And even to just keep double checking and keep checking in with that data, because things are changing every minute, I went, when I heard the governor's press conference on Wednesday, I think it was March 22nd, And Governor Whitmer was saying that when you look at our state and our shutdown, it's working. And if you look at the states that don't have lockdown orders in place, you could see it's not working for them. Their numbers are increasing. They're seeing more deaths and more COVID-19 than we are. So we got to keep on doing what we're doing because it's working. I knew I had to say something because I knew that the numbers showed quite the opposite picture. So I did a video for you guys. I recorded it that night. I believe we might have posted it to Facebook the next morning. So April 22nd, April 23rd, it's made available public on my Facebook page. You don't have to be my friend to see it. And I talk about what the numbers looked like on April 22nd. So we have his original numbers from April 5th, my numbers from April 15th, the updated numbers from April 22nd, and these, I say his and my numbers, these are not numbers we created. These are numbers reported worldwide about the infection rates from these states. And then the same, we have these updated numbers for the states as compared to their neighbored states, showing that clearly these lockdown orders are not working. The states without lockdown orders are faring far better. And to the point that someone recently made to me, I think it was just last night on a Facebook comment, well, you can't just account for population because we're also looking at population density. And obviously in a place like New York City or in LA, we have, I don't even know what the number is, if it's, 4,500 people per square mile versus, you get parts of Michigan, I think, right here where we're sitting now in Hudsonville, it's the general area of Georgetown Township might have like a 1,700 people per square mile population density, so it's far less than what you would see in New York City, which would explain why Detroit, has possibly more cases than what we're seeing over here. However, and this is just so recent to me that I did not get a chance to double check, but I do know that there are studies that were done specifically accounting for formulas put out and published for the public to see that accounted for not only the population differences, but the population density and a few other important factors where others might say, well, that's not going to be statistically relevant because you didn't account for all these differences between the states. There are experts out there who have done that, who have run the numbers, who have created an algorithm that talks about how can you see the spread moving one way or another, whether it's a state like Minnesota that is, medium population density as compared to the United States, or high versus an area like New York City, or lower like Iowa or South Dakota. That he plugs in those numbers and it shows that these numbers carry through. The same patterns we're seeing with his original findings, with what I pulled, 10 days later, and then another 7 days after that, it's the same. So all that information, you could start by seeing it on that document I just referenced. It's available online. It's on my website, khenry4mi.com. But if you can't find it at all, please reach out to me and I will help you find it, because we'll point you right directly to the government sources that give that data if that's what you want.